to his involvement in design options through international multi-center clinical research groups. Apart from clinical practice, Dr. Sathappan was also clinical tutor in NUS, specialty board member of the Chapter of Orthopedic Surgeons Singapore, clinical research coordinator, ATLS course coordinator, and BCLS course coordinator. He has written numerous publications in peer-reviewed journals and book chapters in several orthopedic textbooks. Annually, he is involved in numerous international hip and knee orthopedic meetings as invited faculty, where he often lectures on various subspecialties. Dr. Sathappan has won numerous awards during his training years as a consultant in restructured hospitals. His most recent achievement was EXA Superstar Award 2009, for which he was the recipient for 4 consecutive years for the Gold Award since 2005. Other awards include Yahya Cohen Surgical Award, NUS Teaching Excellence Award, NHG Quality Pair Award, Best Clinical Practice Knee Improvement Award 2007, Young Orthopedic Investigator Award, Hip and Knee Arthritis and Reconstruction Scholarship, Supple Best Student in Medicine Award. Dr. Sathappan, I apologize if some of the words were spelled wrongly, but it just doesn't take away the wonderful sheen that is there in your really fantastic career, sir. So it's an honor to have you here, Dr. Sathappan. And ladies and gentlemen, please welcome me in welcoming our speaker and doctor for today, Dr. S. Sathappan. Sir, the stage is all yours.
Thank you, Anand. Okay, so without further ado, I will take in the slides to go with. This is apart from the joke slide that we had, this is actually a very interesting slide. It looks very much like bone. This is actually exactly how bone is. Very porous looking structure, looks like a cobweb, and many would think that this is actually a bone structure, and exactly the anatomical picture is like a bone, but this is actually a product from a metal called tantalum, and we use this a lot in reconstructive surgery. And it's got probably one of the closest property in terms of bone strength. And I put this up because this is where our technology is leading to, both cartilage scaffolds and bone technology or bone mimicking kind of metal technology. And bone is such an interesting structure. People often think of it as a solid block. It's not. If it's a solid block, it's going to be very heavy. It'll be durable, but extremely heavy to move around. So it's a structure that very uniquely designed with a porous element to make it light, but an interlaced kind of web network of protein and calcium and many other mineral structures to give that scaffolding structure that gives a humongous strength, durability that sees us through our multiple decades of life. Thank you very much for the wonderful introduction. For those of you who joined in late, just a very brief insight of my career. I am very passionate about orthopedics. It's been my bread and butter. Maybe one half of my body is really all thinking about orthopedics. I've been in orthopedic field since 2001, and it gives me great pleasure in training numerous orthopedic trainees who are now consultants themselves. So I've been a program director training young orthopedic trainees for about 10 years when I was in the restructured hospital. My experience in computers, I have a huge passion for IT technology, huge respect for people in the attendees who are attending this talk who are in IT, because I think that's where we are going and heading towards. But it's merging of computers, robotics, IT, software, hardware with medicine. That's where we're heading over the next 3 decades. That's how it's going to be. As an arthroplasty surgeon with a huge interest, I do joint replacements. In my most labor intensive, when I was in restructured, I was doing about 200 to 300 joint replacements a year. And I've seen through 3 different generations of arthroplasty systems. So without further ado, with that in knowledge, I would like to take you down to the next series of slides where I will try to take through different facets of orthopedic surgery, trying to cover hip and knee problems and other elements, and hopefully whatever I've not covered, I would be most happy to take that in the Q&A directed by Anand and his colleagues. And of course, if there are anything further, we can see how we can reply to that via electronic means, emails and Facebook. All right, so really, I put this slide up because we are not all relating sports only to 20-year-old, 30-year-old. And I see people with sports injuries at the age of 60, 70, 80. So age is just a number, a cliche to use. But people are very active, and that's how we want to be. And with this, we see a myriad of problems that can start from the bottom up. You have people presenting with heel pain, plantar fasciitis, stress fractures, shin splints, knee injuries, which form a big bulk of my patients, and even soft tissue injuries in the hand when they are involved in racket games, and of course, fractures. So, if I was to summarize my experience in seeing in my clinic patients, you would divide it into two main elements: acute and elective. A very simple way of defining it. So, and then you can subcategorize. I like to always, when I teach a lot, and I like to categorize my brain, and that allows me to share with my patients. So, acute would include fractures, ligament injuries, muscle injuries, and you see how I chose the words. These are all different structures that form part of the musculoskeletal system. Elective, similar soft tissue structures as well, but you can kind of wait, plan, and do. You don't really have to rush and do it overnight or within the next couple of days. So, for example, Anand was saying about my surgical commitment tonight. I have a femur fracture to do, so that's an acute example. But tomorrow, I'm doing an elective knee surgery that has been planned and requested by the patient 2 months ago because she has defined a time period. So that forms really, in clinical medicine, a very important segment when we deal with patients. So if you start talking about hip and knee, you can look at it from outside to in. So you've got structures which are very similar, whether it may be the shoulder, the upper limb, lower limb, etc. So, for example, in the structures that outside are skin, but deep to it you have muscle, joint capsule that provides structural stability alongside static stabilizers called ligaments, bones that form, as I showed you a first slide, is basically a skeletal scaffold, and then cartilage, which basically is a mobile joint bearing kind of surface that allows lubrication and movements to occur. So this entire composite, even though the slide header is a hip and knee, is how our musculoskeletal system, or MSK, functions. So if you take a knee joint, so if you look at it more intuitively, you have on the right-hand side the femur, the tibia, which form the structural elements of the knee joint, the patella, which is really like a pulley. So as you would have water in a well, and you want that wheel to be very smooth so that you can draw the water out of the well, the patella forms a very important function. So some of us would have relatives or ourselves would have difficulty getting up from a chair, and you have that pain in the front of your knee, or your relative may complain, or mom may complain about that pain in the front of the knee. It's often to do with the patella, and where the patella cartilage is worn out. And people often equate that to the word kneecap, but kneecap is a very loose term that we use in layman term. But medically, when you relate that, it's actually the patella. But people refer to the kneecap as the entire knee joint. So, pardon my bluntness in the picture, but this is a very old picture that I have on the left-hand side. I used to tutor on anatomy of the knee structures in my NUS days in 2000 period. And this is a picture I took at that time. It's a cadaveric model. It's a bit more difficult to get these kind of models, a description for medical students nowadays, unfortunately, for various ethical and clinical reasons. But we have virtual anatomy and models. But this is a good picture just to show you how a healthy cartilage would look like. So you can see that glistening, shiny white cartilage, the holy grail. We find it very difficult to replicate. We're getting there, but when I was a trainee in the period of 1999, at that time, we used to talk about the cartilage scaffold having been successfully replicated in rabbits. And we thought in 10 years, we'll be there. I'm a consultant already for 23 years now, and we've still not been able to substantially say we can stop doing knee replacements. That scaffold is good, but it still needs to be better because it doesn't last beyond a period of 7 to 10 years. So we thought it'll last forever, but it's not. And the picture on the right-hand side shows the X-ray picture of exactly the schematic diagram I showed you, and the left-hand picture of the knee in opened-up model. So you have the femur on the top, tibia on the bottom, and the different structural elements that we talk about. The space that is there, you can't see cartilage on X-ray. You can make a rough guess that the cartilage space is pretty good. But if the cartilage becomes thinner and thinner, the two ends become closer and closer, as we shall see in the subsequent slides. But other technological elements are there to look at it more intuitively, such as MRI. So this is a very old slide from my research days. So this is a cartilage, human cartilage cell. You can see how very healthy cushion, and there are these spotted structures that you can see here. These are the beautiful chondrocytes that produce that chondral matrix that gives us that cushioning. Now, this is the same cartilage slide of an elderly individual. You got to really search for the spotted cells. Lack of chondrocytes. In essence, that defines what happens in osteoarthritis. You start to deplete your cartilage cells, you lose that chondral matrix, and then you get knee pain. Where's the bone in this slide? You see, this structure is the bone. This structure is the bone here. So when that cushioning is lost, every time you do that jump, you do that kneel, you run up the steps, you're pounding the bone. People often think that the cartilage has got pain fibers. That's why they're having the pain, because the cartilage is thinned out. Wrong. The cartilage is aneural. The word aneural means no nerve innervations. And how do you experience pain? It's because the bone ends have the pain fibers. So when bone experiences undue stress, it becomes painful. That's why. And then when I try to explain to students or to patients what is cartilage, think of it as, for some of us who do housework, you'll have a sponge to clean tabletops or your dishes and everything else. You soak that sponge in water and you pull it out, and then you kind of squeeze it. There's still so much of water that comes out. Another sponge that's not so great, you soak it in and you pull it out, all the water drips out, you squeeze, hardly any water comes out. The first sponge is like good cartilage. It has an amazing water holding capacity. Whereas the second sponge, which is pretty dried out, has got very poor water holding capacity. So same thing goes with this micro slides. The first sponge would be the first slide, which is amazing chondrocytes, cartilage matrix, chondral matrix that holds the water very well, despite you jumping and kneeling and etc. etc. Whereas the lousy sponge would be the one when you get older, the cartilage is already depleted of chondrocytes. They are unable to hold that water well. So every impact goes straight to the bone and you get pain. So that's kind of like summarizing a 20-page article on cartilage and how pain comes in a very simple way. So arthritis, what does that mean? Joint, arth, Latin term, itis is inflammation. It's the same term some people would have an eye problem, conjunctivitis. Conjunctiva refers to the outer lining of the eye. Itis is inflammation. So it's similar, but here we are talking about joint. So I've already elaborated on how a cartilage works. It's a shock absorber. And when you have joint destruction and the cartilage ends are no longer capping the bone well, then you have bone and bone grinding, such as in the schematic picture. And then you have pain, deformity, because there's going to be a functional mismatch between the two ends of the bone. And the lining of the joint becomes inflamed. Just as you would if you knocked your hand against the wall, it swells up. So because it's not something that normal that we would do and causes injury. And same thing happens in the knee. Now, you saw a picture earlier from my science laboratory that I was teaching students in, and this one is in the knee surgery picture. And you can see how that glistening cartilage is missing. It's all rough, raw bone, ligaments are dysfunctional, and this would be how an arthritic joint would look like during a knee replacement surgery. In an X-ray picture, we saw a normal looking X-ray before, and this is very early arthritis, slight joint space narrowing to the overlooking eye. You don't really see much of a problem. But look at the same individual on the other side. He's presenting with knee pain. The cartilage space that I told you about is narrowed down. As such, he will have joint pain. There is overloading of the bone, so you end up getting all these small bone spurs called osteophytes. Same entity in the hip, where there's supposed to be a nice joint space. The head is a very spherical joint. So here you lose that sphericity. Here it's a little bit lesser, but there's also joint arthritis. So osteoarthritis is basically where cartilage becomes eroded, bone spurs form here, and then why do bone spurs form? Cartilage being absent, the bone is extremely stressed. It tries to produce cartilage. It's a failed attempt. End up producing these spurs. In medical terms, we use a law called Wolff's law. So when you stress the bone, it reacts, and these spurs form. To the surgeon, we use that to diagnose osteoarthritis. To the patient, they will say it's rubbing the ligament and causing them pain. And of course, it may cause limitations in their functional activities. The causes of arthritis, you can broadly define into age-related. So if everybody lives long to the age of 150, even if you've got the best of genes, you'll probably get osteoarthritis. But of course, there is a multiple factorial event. So weight, lifestyle, how you take care of your joints, what trauma you accrue over time. Trauma. So you could look at somebody who's 20s, multiple knee injuries, sports injuries, and then you basically have progressive osteoarthritis. Then my patient will tell me, no, look at the English club soccer player. He's playing. After the game, he's back to playing. But see that same guy. Some of you may know Maradona when he was around. So Maradona was super fit, extremely wonderful player. On the back end, you didn't know how many times he had injuries. Every time he got an injury, got it fixed, come back for the next season. But once they hit that post-retirement phase in football, which typically is in their late 30s to 40s, they lose out of shape because they've accrued so much of injuries. They get very severe arthritis. He put on a lot of weight, and essentially that also adds on to a lot of osteoarthritis. But why did he gain weight? Because he was getting so much of pain, he couldn't keep fit with exercises. So osteoarthritis is traumatic related as well as age related. In some patients, they have an inflammation. We have a autoantibodies. These autoantibodies are immune chemicals that we release in our body to fight infection. Sometimes, in some of us, due to genetics and other causes, we end up producing them for unusual reasons, attacking our own structure. One example is rheumatoid arthritis, where I've had patients as age as 32 having a knee replacement because since the age of 14, they've been having severe arthritis and joint pain. So that progressive insult to the knee over a 14 to 20-year period, they have subsequent need for knee replacement at such a young age. Generally, most of my patients are in the 60s to 80s. My oldest patient having done knee replacement at the age of 89. So, schematic look of the X-ray again. So very mild, moderate, where there's so much of dysfunctional changes, there's even joint collapse. It's severe. So in early phases, you can manage the medications and injections, but in late phases, sometimes you have surgical options that are required. We talked about pain and deformity. So dysfunctional status, where there is joint malalignment and the knee is entirely bowed, as people often say, limiting in function. This patient presenting with wheelchair. He's not able to walk and he can only do stand and sit, and becomes a very severe restriction of activities of daily living. So we talked about the cartilage loss that leads to dysfunctional joint space and tension, and then you have bone cysts. What are bone cysts? When you have severe cartilage loss, there is micro cracks in the bone, and joint fluid can seep into the bone, just as water would seep into your broken tiles and lift off the tiles. Same philosophy. So you get these bone cysts forming, and they can add on to pain that is experienced in the patient. So, does all knee arthritis need surgery? No, I think it's like saying every cardiac disease needs a bypass. Incorrect. So I think it's about disease containment. You got to first of all understand the problem. It's not just about patient, you tell them osteoarthritis, you got to go for operation. I think you need to bring insight, maybe diabetes, blood pressure. Insight into the patient is a big successful factor for good treatment, irregardless whether it's surgery or non-surgical treatment. So without insight, your best surgical patient will also not have a good outcome. So understanding the problem, as we have using this particular forum, or your other media and your doctors, etc. Exercise, very important contribution. So range of motion exercises decreases stiffness, strengthens up the muscles, decreasing the joint overload. Sometimes you need anti-inflammatories so that it can jumpstart you to doing exercises. Sometimes patients are very resistant. They say, I don't want to take medication. So then pain, put on more weight, muscle become weaker. It's a vicious cycle. So sometimes for a short period, getting them to jumpstart, it's perfectly okay. Heat and cold, very common question I get. So in very severe inflammation, you got to stick with the cold. But in the more stiffness kind of pain, you usually use heat packs to reduce the aches, improve the stiffness, and at the same time increase the circulation. So let's look at a clinical situation. A 55-year-old lady presenting to me with 6 months of worsening knee pain, difficulty in doing what she's very passionate about is line dancing. Not lion dancing, but line dancing. Initially, I mistook it for lion dancing when she told me that. So, basically, she was also unable to walk continuously for more than 40 minutes. Stiffness and occasional swelling. But as I've educated you, the X-ray doesn't look too bad. There is a bit of joint space narrowing. Does it need a surgery? Obviously not. So she needs something like this, but in a synergy. So basically what we're talking about is if you have a door that creaks, do you mean that you have to change the door? No, you lubricate it. So in her case, we can lubricate, we can introduce an injection. It's a viscose supplementation injection that can be introduced into the joint to facilitate in the movement. And that can be in the form of a hyaluronic acid that can be administered in the clinic setting. And there are different various forms of it. Nowadays, we give it in a single injection version. And if you look at the ladder of joint arthritis and management, there are different ladders that we talk about and the rings of the ladder. So from the over-the-counter all the way up to joint replacement with an intermediary such as intraarticular hyaluronic acid that we talked about. Look at this 40-year-old gentleman, 3 months of worsening knee pain, but interestingly, he's been very well. Everything started after a smash during badminton. Complaining of what we call in medical terms locking, or the patient describes as jamming of the knee. But if you look at the x-ray, there's something floating inside. So in this particular individual, we did a knee scope as a keyhole surgery, taking out that small loose fragment. And it's actually a broken osteophyte, a bone spur that I talked to you about. So in this individual, one of his injuries had caused a breakage in the spur and resulted in floating it around over time and presenting with this particular mechanical block that he improved dramatically and was back to playing badminton in 6 weeks after the surgical intervention. Now, this gentleman of mine is actually a 49-year-old, very active. He used to work in the army when he saw me at that time. So he's a warrant officer and essentially presenting with knee pain. Very interestingly, you can see that the x-ray looks very benignly normal with very minimal joint space narrowing. Difficulty in walking, but very active guy, wants to maintain his fitness level for his bonus. And he also plays golf, and he couldn't play golf anymore. So he tried injections with my GP colleague of mine, and then his GP colleague referred him to me, and I said, let's have a look. Unusual, you have a lot of focal pain, let's get an MRI done. So MRI shows a lot of edema. So for those of you who have not seen MRI, this particular sequence, the T2 sequence, bone will appear pure black in color. So, but interestingly, the bone here looks very white. White is water signal, inflammation. So it's picking up a lot of inflammation that we couldn't appreciate on this particular X-ray. So with his, basically, I said, you have a cartilage damage. He's very active. So we will talk about cartilage transplant. So we take out those cells inside, wherever that can spare some cartilage cells. Then we grow it in the lab. It comes in this kind of jelly version. And when we open up his knee, we can see that defect that is there. It takes about 2 weeks to grow this jelly. And then we paste it down, and then basically we patch it up. And then after a protocol of rehab and everything else, he was back to his IPPT within 6 months, very active and pretty happy. So technology moves in paradigm shifts, and this is one of the ways in which we would address knee pain in that individual, and he doesn't need a knee replacement surgery. But that requires about 2 surgeries. But technology moves, and this is a scaffold from stem cells and cartilage technology where we produce cartilage matrix. And in this patient who's a avid dancer and dance teacher, in fact, so she had a lot of kneecap pain. So kneecap, patellofemoral, which I told you about. So she's finding it difficult to do all the Bharatanatyam maneuvers to demonstrate to her students. So for her, you can see that in her side that she's barely worn out everything. So I use cartilage scaffold technology to do drill holes. It's called microfracture, but we patch it up with this particular membrane. And the membrane's got 2 sides to it. So there's a bone side and a cartilage side. So we have to mark it. So you see I've put in the blue marking so that I don't get confused. There's a rough and a smooth side. And then we patch it up. And similar protocol after surgery, back to dance teaching very actively at about 7 months after. So pretty happy. And more technology comes in over the last decade. So you can see now we have even keyhole method of doing something called cartifill. We inject it on the spot. We see the defect, we patch the defect, and we spray the gel. And this is what, so you saw one of my first cartilage transplant slides. That slide that I took out was from 2006. And you can see how through the years, over a period of 15 years, you see different technologies moving and moving forward. And in some patients, they have malalignment that I talked about. Sometimes the malalignment is substantial, and just cartilage patching may not be sufficient. You need to realign the leg, otherwise you overload the patched up area. In such context, then you have to do realignment procedures, and we call that realignment osteotomy. So you saw the same picture I showed you of an older individual, and this is a very young individual. So when you have a bow-legged, you try to make that into a corrective neutral anatomy. I normally use computer technology. So you see this navigation trackers. It's like a GPS. It gives us alignment guide to align the knee, and this same individual, very active rugby coach, you can see that his joint space is narrow, and this yellow line is actually called a mechanical axis. When you stand, jump, do stuff, your hip, knee, and ankle are almost in one straight line. The center of the knee is here where my arrow cursor is, but his mechanical axis is deviated to the inner part. Thus, he's getting a lot of knee pain on the inner part. You can see his right knee is pretty okay. Now, what you may ask, why? What happened here? He had an old meniscal injury for which he had a surgical intervention done by one of my ex-senior bosses, and he did very well for quite a number of years. But along the way, when he hit his 40s, a lot of knee pain and arthritis. So he saw a colleague of mine who said knee replacement. I said, you're 49, you're very young. Hang on a second. Maybe we offer you an alternative option if you're willing to take a slow, steady protocol. So we did an osteotomy, and I combined it with patching. So the cartilage scaffold that you saw. Back to rugby coaching in a year's time, pretty active individual as well. So we have delayed his need for a knee replacement at least for the next 10 to 15 years. 55-year-old lady, secretary in a legal firm. So a lot of pain. She's tried injections before, so maybe not the best candidate for an injection again because it doesn't seem to work well. So for her, I offered a partial replacement where you essentially replace the knee on the inner part, but all of the sides are pretty good. So you don't have to, and for her, she doesn't have the length of time and patience and physique to use crutches and walking aids for the initial period. So, and she wants to get on back to activity ASAP. So you do this partial replacement, you get them walking the next day, and within 6 weeks, back to work, full swing. And in some patients, the arthritis is very global, and you can't do a partial replacement. Then you have to definitely do a full knee replacement, And the concepts involve very similar but extended versions of what we just talked about. The philosophy, really to make that bow-legged into a neutral alignment, such as we see in this staged knee replacement done for this patient. That leads on to, as I brought you through the different generations of cartilage matrix that are available, this is likewise for joint replacement, robotics, and computer-aided technology. Not to dwell too long, but robots have been with us for a long time, since the 1950s. And in terms of medicine, bringing artificial intelligence is from Professor John McCarthy, trying to integrate computers and repetitive modeling and applying that into medicine to reduce human error. And it's already used in various facets of medicine, cardiology to look out for sudden fibrillations where the heart goes a little bit crazy with the beating rate, sometimes for patients with epilepsy, fits. You can place certain devices and they can keep it in their pocket, and essentially it pre-detects the patient's going to have an epileptic fit because of sudden aberrations in electrical activity in the brain. So such as technology is becoming very, very advanced in picking up problems before it even happens. In orthopedics, we use it for accuracy. So really, it's a tracker device that we can use to replicate and give good alignment and predictable outcomes and faster rehab in patients. And this is what, I don't think any of us would use a street directory anymore. And this is where we came from. For some of you who recognize the Garmin, but now it's available on our handphone. We use it to GPS our way all around. And even for that matter, pilots fly multiple countries and continents with brilliant modeling systems that allow them to get from point A to point B very safely and accurately. And technology has been existent in robotic technology, computers, in factories and industries for a long time. But I'm showing you this slide is knee surgery in my 90s. We were still doing patients with knee replacements using crude models and equipment where we use basically what we often term eyeballing. That means experience and alignment. But this has to move on. So we bring in things like computers, navigation, which has tons of data, allows the patient to have data accrued during the surgery. And this allows like a GPS tracker for the knee to get that alignment that I showed you earlier on as perfect as possible. And it becomes your eyes really. So you can do small incisions, you got computers to guide you to get that implants in, to get a good, reproducible, predictable outcome. And you have patients with severe deformity. Varus is a deformity of 20 degrees. You bring it down to 90-degree correction to make the knee as straight as possible from this crooked knee that you have here. And Anand talked a lot about Mako. So Mako is one of the robotic technologies that I use a lot. And it's been around since 2006 and driving in all the way to the present time with multiple increments of improvement technology. It allows to reduce error, and we use it a lot in partial replacements, but it's also starting to take a foothold in full knee replacements as well. And originally it was owned by a company from Restoris, and now it's under Stryker. And really it's about perfection, bringing that all to 1 millimeter accuracy, giving that surgeon data acquisition to make sure that as you would drive your car of current technology, where you can see how's the ignition, how's the petrol, how's the estimation economy, fuel usage, the same way we would use that numerical data to maximize in the theater to give maximum long-term outcome for the patient. You can use it for standard partial replacements all the way down to complicated replacements when patients have got hardware inside you. And in the simple schematic version of that is basically this patient with knee arthritis, which is starting phase. And then you do this with a small incision that doesn't need to really affect the patient in terms of rehab and recovery. And you can extend that technology into various types of replacements. It can be on the inner side, it can be on the outer side, it can be on the front. And a lot of it involves CT scan, where we get acquisition of data, just like you would get to type a postal code to get to a place. We need to get some information on the patient's anatomy. This is then put into the computer sequence, and then the robot comes into play. And during the surgery, this is how you would set it up. You acquire a lot of dynamic data of the patient. Then I, as a surgeon, will tell the computer where all the surgical anatomical landmarks are. And then during surgery, we bring in this robot to execute and placing these implants. And these are pictures that we get live data when we're doing the surgery, how accurate the cuts are, and how the whole process is ongoing. So in this patient with knee arthritis on the inner compartment, we have done a knee replacement, partial knee replacement on the inner side. And in various patients where you can do two compartments, and you can restore the mechanical axis back to its neutral axis as well. Patients often ask me, can you do this after knee replacement surgery? I think good patient selection, and at the same time proper rehab, it is possible to achieve that, definitely. And through small incisions, good physiotherapy input, and getting the patient back to active lifestyle. That's the intention of any good orthopedic surgeon. One of my Muslim patients, and basically his most important was for kneeling for prayer. He can get back to it, and he's doing it comfortably and without any issues. And one of my other Indian ladies who loves to do yoga and everything else. So you can see that basically she can do a cross-legged sitting with no major difficulty and essentially with no limitations. In this patient, I did a bicompartmental replacement, very active, does a lot of mountain climbing, goes up to Himalayas and everything else for prayers and everything, and he's very active. Patient-specific implants, as technology gets into 3D printing, in some patients, they have very unique size, very small, or very limitations because of multiple hardware from previous sports accidents and injuries. So that makes it a challenge when you want to use this kind of technology that we talked about. So we model the knee the same way with the CT scan, and then we produce the implants for them. And I've actually come up with talked about this in the press many years ago when we first did our first case series at the time. And in this particular patient, left knee, very small, petite lady. And so we do the CT sequencing, we get all the information in. Her implants come delivered like a pizza box, everything inside, and all the cutting tools required only modeled to fit her knee, nobody else's knee. And then implants designed only for her knee. So exactly perfectly fitting and getting back to functional activity with no major issues. Now, from the knee, we just have a quick glimpse through, I think probably the next 10 to 12 minutes. I'm just going to try and cover as many things as I can. So this gentleman, 37-year-old, presenting with pain. Hip x-ray, as I taught you, looks pretty reasonable, but he had pain with squatting. So this is a cartilage, like we talked about in the knee, but it's called a labrum, and there's a tear in the cartilage. There's a gap here. So in him, we have to repair that. So the labrum has to be stitched. This is a keyhole surgery, and we put that stitch to facilitate the joint loading, just as we talked about the knee in the hip for that matter. In some patients, they have severe cartilage loss and they have collapse of the bone, and that's a problem. And if it's in a very young patient, we don't want to be immediately jumping to the hip replacement. So in that patient, this patient is about 26, and this is a very old image that's done about more than 15 years ago. And you can see that he's got very young to have a hip replacement at the age of 26. So we basically clean up all the dead bone and the collapsed segments here, and we will put in a live fibrillar graft with a blood supply hook it up to a nearby blood vessel to bring some degree of life to the hip and make it survive so that we can delay hip replacement. And we have put that structural scaffold, and he's doing very well. It's already 15 years since seen him, and he comes back once in a few years for a checkup, still doing good, no need for any hip replacement. So that's a life fibula graft that we've done for this patient. And we published this in our case series years ago. And in some patients, beyond a certain age, it may be difficult to do such a procedure. Like a knee replacement, we will do a hip replacement. The concept's very similar. So, but here there's a socket and there is a femoral head that we utilize to replace. And this is a slight surgical model showing you how the cartilage is very beautiful here, but with arthritis, there is hardly any joint space that is visible in this particular picture. And in such a scenario, we'll give a hip replacement, and going even beyond the history of knee, hip replacement was one of the first most successful joint replacement surgeries, and it's become very reproducible, very good outcome for patients. And here you can see in this particular slide, there are multiple bearing surfaces that we use in patients. And here in young patients, sometimes we can't use always metal and poly because it will wear out very quickly within 20 years. So nowadays we have ceramic. There used to be metal on metal, but we have to always audit technology. Metal on metal has unfortunately fallen out of favor. So we mainly stick to ceramic on poly, ceramic on ceramic, or poly on metal on poly. And robotic technology and computer technology has also made a foothold in hip replacements, giving you that 3D perspective to reduce the risk of dislocations and instability, such as we see in this picture. And arthritis can also be in the elbow joint. And in some patients, I don't see this a lot. I probably do a couple of elbow replacements a year. One of the few surgeons in Singapore who do elbow replacements. So patient presenting with severe arthritis, similar technology, but not as advanced because it's not many patients that we do that. And the design allows the patient to get back to functional activities of the elbow. Common terms that patients sometimes ask me questions about: sprains, injuries to muscle. Strains are often injuries to ligament, but it's a very often mix and match kind of term that people often use. Tears usually refers to muscles and ligaments. So if you talk about ankle sprains, for example, so usually it's the outer ligament more than the inner ligament, and sometimes you can have it in the foot as well and the wrist. Ankle injuries, basically people ask, do I need to get an x-ray? Most times when you can't weight bear, that's a problem. Or the severe bruising, as you see in this picture, then you need to get a consult minimum from your GP, and if it's appropriate, he will refer them to a CA or orthopedic doctor. Most simple strains improve within 3 weeks, but in some cases, you may need additional adjuncts such as physiotherapy and proprioceptive exercises. In patients having recurrent instability, you may need to consider ankle ligament reconstruction. Now, just to show you an example, not all foot sprains are simple. This particular patient had a foot sprain, seen by a junior doctor in A&E, told normal, came in with severe pain, unable to weight bear, already about a week with that problem. And then when I saw that, I said, no, you have torn your ligament. We got some investigations done, such as MRI, confirmed it. And then we had to repair that ligament and offload it with a plate. And then took off the plate after 6 months, back to his active job and as well as running. In muscle tears that we talked about, you can see the rotator cuff is a shoulder muscle and it's detached off this on the footprint on the greater tuberosity, and that has to be addressed. And that's the same muscle that you saw just now on the MRI. This is the supraspinatus muscle that's attached to the greater tuberosity. And when the tear is large, in some cases, you need to do surgical intervention where you repair the muscle using suture anchors by keyhole method. And rehabilitation is a very important part and parcel of the recovery process. A 38-year-old gentleman playing football, acute in the calf muscle. And essentially having severe pain, unable to do a tiptoe, very weak in plantar flexion. Tiptoe will be the plantar flexion movement that we're talking about. And if you do an MRI, you can see that there's normally you should not have so much fluid between the muscle gaps. So it's a torn muscle. This corner is supposed to be down here. So that's completely torn. So you don't have to always operate. There's options. He's a gym instructor and he's running a gym. He says, hey, Doc, I can't be out of action for 6 weeks and then another 6 weeks of rehab. So we talked a lot about surgical intervention versus non-surgical intervention. We talked about repair. So he says, go with the repair. Repair, we do something called PRP, platelet-rich plasma, and then start weight bearing within 3 weeks. So, and then he's back to sports at 3 months. So it's like half the time. What's PRP? So you take that blood from you distill it, centrifuge it, and then distill it, and that good stuff, the platelet-rich plasma, is basically decanted, and then we basically use it for injecting into muscles and soft tissue structures that have injuries. And essentially, what is PRP? Plasma with many more platelets. It helps in chronic injuries and with recovery, and it's a very growing trend, but appropriately utilized. There's excessive commercial intent sometimes when you see it being published a lot in the Google and everything else. So take it with a pinch of salt. Sometimes I've got patients coming in with severe osteoarthritis, totally wheelchair bound. Can you do PRP and make me walk tomorrow? I think it's been impractical. So I have to educate the people on where you can apply, where it doesn't make sense. All the pain that we talked about, always from the hip and knee, if it's a leg pain, no, you got to be careful. You have to assess properly. So this 48-year-old gentleman presented me with hip to knee pain. And it was interesting because he was seen by another clinician and offered knee surgery. He wanted a second opinion. So he came to see me. I said, hang on a second. I'm examining your hip and your knee is pretty good. He showed me his knee x-ray. There was a bit of early arthritis, but his pain was phenomenal. So I said, I have to reevaluate you. So I did some tests and I was quite correct in my conviction. I suspect you have a spine problem because you have a sciatica when I examine you, which doesn't make sense. Your knee x-ray is too good to have a knee surgery. So I did an MRI, found a big disc that's pressing his nerve. We did a surgery for his spine. We walked out of the clinic very happy after the surgery and pretty happy. So I think the importance is, as I teach my students, the clinical history. I think technology is very good, but sometimes I get a bit sad when I teach students and I ask them, how do you diagnose meniscal tear or knee osteoarthritis? I do an MRI. I said, what happened to talking to the patient? We have become, technology is good. I'm for technology, but you must make it work for you. You don't work for the technology. And then last few slides, thanks for staying with me. I've covered from hip, knee, shoulder, elbow, foot and ankle, and I'm coming to the final. I started with the bone, I end with the bone as well. All right, osteoporosis, one of the biggest challenges we are facing nowadays with the aging population. And for those of you who joined me in the beginning, would remember I showed you a picture of bone, but it wasn't bone, it was metal, yeah? It's trabecular metal. And that is one of the best technology we have that looks exactly like bone. And we use it for complex reconstructive surgery. So see how that same structure is like this? So bone is a scaffold, it's a network with scaffold filled with proteinaceous material. Unfortunately, when we become older, this is how it looks like. Too porous, too empty. And that's why it breaks easily. So that balance is very important. So I won't bore you too much with bone biology, but bone basically goes through this cascade of changes from our puberty days. And when that balance, what is the balance? It's so yin and yang. In Ayurveda, we will talk a lot about everything has to have a balance. So likewise, production, but excessive production won't become too high. You need to also have some destruction. So there's some breakdown. Too much breakdown, bone becomes weak. So that balance is interplayed by these numerous structures in our body. Maybe vitamin D, hormonal balances, your milk that you take in, your body's ability to utilize these things. Thus, any one particular thing has a hiccup, you have a disease there. That's what happens. The net outcome, osteoporosis. So, as I always love when I teach, I like to integrate it with clinical cases. 50-year-old lady presenting with just with a simple fall, shattered radius. This is what I would see in my motorcyclist patient. Why should she break it so badly? So definitely you think about osteoporosis. So weight is very small, height is small, high risk for osteoporosis. Ironically, we've always strived to be thin, but fat is actually a protection for osteoporosis. Then patients say, how come? Why is it so good? Because when you load the bone a lot more, bone becomes hard. So, but of course, it's not healthy to be fat, right? So your heart will get screwed. So you got to be careful. That's always about balance. So you don't want to be ultrally anorexic kind of weight loss, but you want to be healthy about it as well. So osteoporosis is whereby your bones become too weakened and the risk of fracture increases. And what we talk about fragility fracture. So no one would just walk, land on their butt and break the hip. That's abnormal. So I would call that a pathological fracture. And why is it pathological? Because bone is too weak. And that's why we call it pathological. And one commonest disease of pathological fracture is osteoporosis. And we would do a bone mineral density scan to see how porotic the bone is. Hip fractures are increasing, and we would look at hip fractures and vertebral fractures as a very dramatic change to the patient's outcome. Why? Because you can't walk, it's very painful in the back, and once you and I, we take it for granted that we can walk, we can sit, we cough our phlegm up, we need to take a pee, we go to the toilet and we take a pee. So it's very natural process we take for granted. But once you have a hip fracture, you're not able to walk. So use it, and you may not clear your bladder that frequently. You get a urine infection, and you're not able to sit up properly because of pain. You get pressure sore. You're not able to clear your phlegm easily. You get a chest infection. Thus, a hip fracture, most people don't die of a hip fracture. They die of immobility-related complications. And that is the challenge that we, as medical physicians, surgeons, or for that matter in Singapore or all around the world, we want to address that with the aging population, reduce hip fractures or spine fractures because it adds not only economic burden to society, but a psychological burden to the patient and socio-economic psychological burden to the family as a whole. So that drive should be towards reducing the total number of patients with hip and spine fractures. So we can see this old data, how there's an exponential increase in hip fractures as we get old. And I've already talked to you about the interplay of multiple factors. So all in balance, no excess alcohol, lack of exercise, all these things will have an interplay in contributing to osteoporosis. Now, patients will say, when do I, doc, I'm going to take lots of milk. And yeah, it's going to be useful, but actually, sadly, the peak bone mass is reached a peak at the level of 30 plus. So it's very important to educate your kids and yourself if you're in your sub-30s, that's where you reach your peak bone mass. Then my 50-year-old patient says, oh, that's it, I'm done for. No, not true. Bone's still building up. You still have chance. May not be as great as in your 30s, but doesn't mean you stop. You still maintain a healthy lifestyle. And we do things like bone mineral density scans, and these will look at values for T-score. And we have data that is available. We can do this thing called FRAX score. It's available on the internet. You can just go and type the word FRAX score. If you have your BMD, you can type it in. Clinicians, I use it routinely. I show my patients how to use it. And I calculate a fracture risk profile for them, and I have to educate them. Okay, you need some treatment. Okay, you don't need treatment, but you need observation for a while longer. But you take your calcium, you take your vitamin D, you look at your healthy lifestyle. And sometimes patients say, I can't stop smoking, at least smoke less. Okay, so when to start osteoporosis, as I said, as clinicians, we make that balance based on your risk profiling. And you see all these words and jargons. Basically, the producers are osteoblasts, the destroyers osteoblasts, and that breakdown, building up, that's the process that we're talking about. And at this particular table, we use it to fracture risk patient or profile the patient, and then we would accordingly try to either treat or observe and monitor. And by treating appropriate cases, what's the statistics show? It's close to 40%. You may say, only 40%, but it's because we can't control all the factors sometimes. But 40% is a big deal, because if I can, for every 100 fractures I statistically will get, if I can reduce 40 patients and make them better and less likely to have a fracture, that's a huge economic burden that's going to be saved. And we cannot measure the psychological and familial kind of burdens that will be there. So that's going to be also phenomenal as well. 8 ways to prevent osteoporosis. People can read it. I've talked to some of it, but healthy lifestyle. It's all about balance. And that's what's important about a good diet. And in terms of optimizing, I'm primarily 60% of my work is joint replacement. So you want to optimize that range of motion. You want to talk about bone preservation. There's about bearing surfaces, technology. When all integrate into this kind of Zen kind of picture, that's when you get good functional results that we want to give to patients. 1 minute closing slide. So to act, and this may help to answer some of the questions that people may raise on. Fact versus fiction. Glucosamine for joints. No, I think there is no hardcore proof now. It used to be very good, but there's a mild disease modifying effect and a very mild analgesic property. There's a heavy commercial intent. So it does help some people, but not across the board. Milk for joints, incorrect. Milk is for bones. Calcium for joints, vice versa. Calcium is for the bones. Osteoporosis is not the same as osteoarthritis. I've educated you. Osteoporosis are one of our last few slides. It's about weakening of the bone. Osteoarthritis is joint inflammation. Will exercise worsen my joints? No, I think it's a balance. So if you have joint pain, then you choose your joint exercises wisely. You don't go pounding exercises. You go for walks, you go for swims, you go for cycle. But if you have a healthy cartilage status, you're very well, I think you can go ahead with your jogs and activity, but remember to stretch, remember to actually eat properly and healthily. Injection for joints, we talked about it. So lubrication in appropriate cases. Keyhole techniques, yes, as appropriate based on the severity. You can talk about cartilage scaffolds, cartilage procedures, and of course, in some instances, arthroplasty, which can be done robotic technology. Computers and robotics in medicine, here to stay. Is there a cure for my joint and bone pain? I think there is, but we can't. And sometimes my patients will come in and say, okay, doc, I'm ready. Let's get on with the surgery. I want you to make me back to my 15 years of age. I said, you're the wrong surgeon. I'm going to improve you to what you were maybe 10 years ago. But if you're asking me to bring your age down to 45 years lesser than what you are, I think we're being overly zealous on that. Thank you very much.
Thank you very much. Thank you so much, Dr. Sathappan, for this really fantastic. I mean, I was really not expecting this detailed level of information, sir. Really, it was fantastic. Really wonderful, talk on all kinds of issues that you can have with your joints all over the body. And what I liked, doctor, and thank you so much for this, is like a picture speaks 1,000 words. So with so many pictures and with so many, whether it didn't look really graphic, to be very honest, and very very nice, very clear, and a lot of information. And the only problem is you already gave answers to so many questions. But I hope that we will have a good Q&As again to the audience. Dr. Sathappan is here, is extremely experienced, very knowledgeable, as you can see. So if you have any questions, please, you can go ahead and ask. I have already some questions from the chat box. So I will go ahead and ask those questions, and then I will open the stage very quickly. I know, doctor, you have very less time, so I will take these questions quickly. So the first question is, doctor, can you explain something on cervical spondylosis?
Okay, so cervical spondylosis is basically a situation whereby cervical means your neck. Spondylosis is a very standard generic term to be used for any degeneration in your disc, your ligaments, and your facets. So in this particular context, patients usually present with neck pain, and also they may have sometimes irritation with the nerve, and the pain can go down the arm. Very common in my clinical practice. I'm not sure. Give me a second. So I'm in the clinic, so I can just. So that's your cervical spine. So for those of you, you can see that. So the disc is that structure in between the yellow structure, between the white structure, which is the bones. So when the disc becomes degenerate, you get neck pain, and when the disc bulges up, how do you imagine that? You look at a cushion in your chair. So when the cushion is good, you're sitting on it, the cushion is really robust. But the cushion is getting lousy. It starts to jut out on the side. There's minor tears in the cushion. The sponge is coming out exactly the same. And when that builds up over time, and in typical age group is 40 to 60, you would term that as cervical spondylosis. Facets of that would be different, where there's severe pain down the arm. We call it radiculopathy, and that will cause sometimes a need for MRI. There's weakness, and some patients need surgery. I would say for every 100 people I see with cervical spondylosis, 20 may need intervention in some form. 80 would be managed with physio, medication, therapy, lifestyle. As I'm for technology, we are one of the causes of neck pain is also technology. So if you don't take care of your posture, the neck, people holding the phone down a lot, people love to do things that they can do on a proper desktop, on a handphone, you're asking for trouble. So balance your time.
Thank you, sir, Doctor. The next question is more general. What are the supplements to be taken to maintain good, healthy bones? People talk about all these supplements. Is
Very,
it?
very good question.
Yeah,
So I
yeah.
think I would divide it into two things. One is basically beyond supplements is your diet. I think you need to eat healthy. So a good spread of vegetables, milk. Some people don't like milk, cheese, paneer. You don't have to always take high fat. It can be low fat based items as well. That would be generic. May you be a vegetarian or non-vegetarian. Unfortunately, sometimes certain vegetarians don't take any dairy products. Then I think you need to supplement that further with your additional tablets that you may need to take in the form of vitamin D and calcium. So a common question I get asked is, what's the dose I need to take? So in general, 500 milligrams of calcium, and you're looking at if your diet is super deficient of any vitamin D. Unfortunately, vitamin D is predominantly found in eggs and the yellow part of the eggs, and at the same time in fish and other dairy products that are a bit more fatty. So you're looking at butter, paneer, and everything else. So if your diet is going to be very deficient in that, and you need to then complement it with tablets, and that's usually 1,000 IU of vitamin D that you're looking at. But if you have a fairly good stable diet, then your multivites, usually if you look at the back end of the multivites, you have about 250 IU of vitamin D, which is sufficient as well. You can complement that with some sun exposure, but you look at the seasons, now the seasons are unpredictable, so you don't get sun all the time. And so I think that's a problem. So you need to complement that with vitamin D supplementation, but some sun exposure will also help you generate that vitamin D as well. Having said that, selenium, magnesium, vitamin C, all these do have some degree of contribution to the different elements of the musculoskeletal system. So they are also important. So good multivites are available in the market that you should be able to get. It's not appropriate for me to mention names of the brands, but be sensible to do your research work a little bit. And I think if you have a family practitioner, they'll be very more than happy to share with you some good ones that you can consider based on your age and your needs.
Thank you. Thank you so much, Doctor. The third question, and I have just two that I've got so far, the third and the fourth. But if there is some more, we will cover it very quickly, Doctor.
Yeah.
The question is, hi, want to know if bone dislocation is a recurrent feature, especially when the patient is young. It's a very different question. And how to prevent bone degeneration, rather how to regress the process.
Okay, so the first one, dislocation. I think people often mistake dislocation for subluxation. So that's the first thing. So dislocation is usually very painful when the joint comes out of the position. And uniquely, it's only common in certain joints at a high risk for young people with sports injuries. It's a shoulder. It can happen in the knee, it can happen in the hip, it can happen in the elbow, less common. All right, so these are all less common. They're high energy trauma. They're very naturally stable joints. So the one that we would see in our practice is usually the shoulder. Sometimes you can see it in finger joints. They can go out of position as well because of rugby and games and activity. So usually it is reduced back, but if it's a recurrent phenomena, then we need to address that with surgical intervention. I think that the participant is probably talking about subluxation, unstable joints that are not completely out of position, they're partially out. So that's a clicky joint people talk about. Sometimes people say, I can pop it out, I can pop it back in. That's because of hypermobility. So some people have collagen disorders. Beyond the scope of this talk, but I talked a lot about cartilage, but collagen is something that makes up ligaments. And essentially, when that collagen property is not great, the ligaments become loose and the joint easily pops out. And it may usually pop out partially in most instances, and the patient is usually able to pop it back in. And those people, they need to strengthen up the dynamic stabilizer, which will be the muscle. And that will reduce the chance of dislocations or subluxations in that matter happening. The second question she was asking about is regression. So I think in the early phases, when you're talking about grade one, grade two, you potentially, with a healthy diet, some supplements that are appropriate, even maybe for that matter, glucosamine and chondroitin, may reduce the progression and potentially can halt. I think there is no study that shows infallibly that you have a grade 4 osteoarthritis, you pump in all that supplements, it becomes a young grade 1 or grade 0. No, we don't have that. So it's a natural phenomenon. So I think we can't regress, to be honest. And I think sometimes surgeons or physicians may try to comfort the patient and say, oh, I'm going to give you this medicine, it's going to make you young again. But it's not really true. It's like saying, your hair is white, but I'm going to give you this magic drop. It's going to be all black tomorrow or over the next 3 months. We know that it's never true. You can dye it, you can color it, but after a while, the white shows. It's okay. So I think it's how you age gracefully, and it's in your hands. You can keep healthy, eat healthy, live a good lifestyle, balance everything. May it be lifestyle, recreation. It's all about harmony. When the body is in harmony, everything is Zen.
Very eloquently explained, Doctor. And I'll take the final question that I've got so far. So, again, it's a question of people like me, the IT professionals. We spend many hours of our day just sitting in the desk, and now we have these fancy tools that tell you that every 15 minutes, every 30 minutes, you need to get up and walk.
Good.
Is this really what we need to do, doctor? In the sense, uh, is it harmful that we are always sitting and it will cause some problems with your bones and joints? And
I,
how often do you think really we should? I mean, it keeps saying every half an hour, and I can't just leave my work and then every half an hour go and walk and come back and So what is this balance? You always talked about the balance. So yeah.
Absolutely. So I think I tell my patients studies show anywhere between 30 to 45 minutes of continuous inactivity where you're sitting for a long time, the disc in the back, in your neck, would get essentially a little bit more flattened, and potentially it would then start to have micro tears in your ligaments and your disc containment structures. So disc is like a jelly in a jelly packet. So if you keep squeezing that packet, after a while the packet will crack. All right. So, and then the jelly will squeeze out. So, and it's not necessarily that one day, but it's progressively over months and days and weeks. That's why patient will say, I've been doing always picking up things from the floor without bending my knees and without tightening my core. But finally, I dropped my pen, and that's when I had it. How can it be possible? It's because the micro injuries have been happening over the last several months. So that's the same analogy, I would say. So studies show that anywhere within about 30 to 45 minutes, it would be good if you can get up, stretch a little bit, let that muscles reset a bit, let that disc come back into position, walk around your workstation, and come back and sit down. And people often tell me, I find it very difficult, it's very disruptive. But be honest to yourself. How many of us look at the phone to check our WhatsApp every 15 to 20 minutes? You mean you have the time to look at that for 5-10 seconds? If you can cut that 5 seconds into 10 segments, that's 50 seconds. You can contribute that 50 seconds to your standing up and walking around. So about 2-3 minutes, after about 5 minutes, timeout would be a good way to reset your body.
Fantastic, Doctor. It almost sounds as if you're talking directly to me. Yeah, the final question that I'll take, I know we are running short of time, is kids complain of heel pain, doctor.
Yeah.
Say growing pain and they advise that, oh, with stretches it will go away. But it's very hard to make them do this every day.
Yes.
Will it go away when they grow older? And is it to be taken more seriously, or it'll just go away later?
Good question. So, in terms of heel pain in children, it's called apophysitis. It's a growth plate that you and I don't have because it's already fused. In children, it's a growing structure. And as they build up muscle mass, it's putting a lot of traction on that growth plate, and it gives them a little bit of pain. So if the child's a little bit on the heavier side, you may get a bit more pain. And when the child is also on the other end of the spectrum, very small muscle mass, and bone is growing at a more rapid phenomena than the muscle mass, and they're involved in CCA. Typically, the age will be anywhere between 8 to 12. That's when they get a lot of these complaints of heel pain. So you can kind of get through that with heel cushions, proper shoe wear selection, proper diet, get that muscle mass better as well. And at the same time, stretches, you rightfully said, would reduce the chance of pain being there because the ligaments have become more flexible. And in that age, it's actually much easier to recover. The same phenomena is in a different version, is plantar fasciitis that we see in adults. And that's a different thing. The tissues lose that flexibility and puts a lot of traction injury to the heel bone. But the treatment, once again, stretches, physiotherapy may be a bit more aggressive in adults because it takes a bit more longer to recover. So when parents ask me, hey, I find it difficult, then I say, you know what you should do? You should stretch with the child. You do the stretching, be an example, and rope them in. So when you get that interaction, it's going to improve your family bond. And not only that, you're going to instill in the child an exercise culture, a stretch culture that they're going to follow through and pass down the generation.
Fantastic. Thank you so much, Doctor. We will just open up the floor for maximum 1 or 2 questions if there is. So anybody who would like to ask, I think the doctor has addressed a lot of very important questions, dear friends. But if there is still any questions, any doubts that you want to ask, please go ahead, unmute yourself and let us know. No questions? Going once? Going twice? Thank you to the audience, and also thank you, Dr. Sathappan, for really patiently answering all our questions, and for this wonderful, really wonderful and very educative session on what we can do for our bone, hip, and generally the joint issues.
Thank you very much.
Thank you very much. And Doctor, once again, we hope that while we hope that we don't get such problems, we know who to go to if we have such issues. So thank you once again, Dr. Sathappan. Any final words, sir, from you to this audience, or should we go ahead with the next?
Yeah. So thanks very much, Anand. It's been a great pleasure to share my knowledge and to also interact and catch up with some new old faces. Mr. Hari, it's a long time. And thanks very much. And I would like to extend my best wishes to everybody.
Thank you very much, Dr. Sathappan. Thank you so much. Of course, this has been a wonderful session. Ladies and gentlemen, this event would not have been possible without the tireless efforts of many of the team members, the organizers, many individuals. And therefore, to deliver the vote of thanks, may I please invite our GOPIO Management Committee member and the organizing chair for the Medical Talk series, Mr. Tam Shanmugam, to the stage. Mr. Tam, the stage is all yours.
Thank you, Mr. Anand. Thank you, Dr. Sathappan, for your very insightful and impactful session today. It was like for some of us, the experience was so nice. We are like inside a operation theater for some time. We are being like listening to a medical talk and a medical school. It was so useful. Even my bones and joints are listening to you very carefully, and it is so nice. A wonderful session, and thanks a lot for taking time and then having all the GOPIO members a useful session. Thank you, Doctor, for this. I also thank our President, Mr. Hari Krishnan, whose thoughtful leadership makes GOPIO very active and useful for the community. And because of him, we are organizing so many talks, which is very beneficial to the community. And health talk is one of the important of the very many activities we do. Thank you, President, for your leadership. And I thank Mr. Anand for taking us systematically through the session, conducting the Q&A to all the audience, collecting all the questions and getting all the questions responses. Thank you very much, Anand, for your time and emceeing today's session. We'd also like to thank Mr. Padhu, whose flyer helped us to reach out to many, and then because of which we managed to get a good audience for today's session. I also thank our Vice President, Mr. Chandra, who is not there today, couldn't make it, but he was very helping, very helpful in getting the session organized with all the Zoom session and all the technical things he made it for us. So thank you, Chandra, for that. Last, not the least, I thank all the audience on a Sunday evening managed to join the session and very we ask all the questions being with us. Thank you very much for being there, and thank everyone for joining this session. Thank you.
Thank you, Mr. Tam. Ladies and gentlemen, with that, we come to an end of today's medical talk session. Once again, a big thank you to Dr. S S Sathappan, to all the people who attended. Just to let you know that GOPIO Singapore would continue to conduct similar events. We do the medical talk on a quarterly basis. We also have business talks, several other health and wellness related sessions. So please be on the lookout for our next event. You can go to gopio.org, as well as we will share these flyers to you on a regular basis. And then please join us, and you would benefit from these sessions as well as from being a part of a global organization like GOPIO.
Anand, before we end, can you put the doctor's particulars on air so that our members can get in touch with him later or visit him later?
Okay. Yeah. Mr. Tam, do you have his particulars directly? I don't have the address and all, but
One minute. Doctor, can I share your card?
Yes, we can share my name card, and the website is all in the name card as well.
Okay.
It is a promotion for him. Good work, good for the help he has given us.
Thank you. So, is it okay if I take leave, sir?
Thank you so much.
Thank you very much, Doctor.
Thank you.
And
Thanks.
thank you, sir. Thank you once again.
Okay. Bye.
Anand,
Yes, sir.
share that.
Now, you would like to share the screen, sir?
You want me to share the screen? 1 minute.
Okay, it's easier, and we can capture it.
Okay. Oh, sorry. I downloaded that. Quickly hit that.
Hospital is number 1, Farah Hospital.
I have that. Oh, I downloaded it. Okay. Let me go and share. You've given me the.
Yes, sir. I've given you co-host already.
Okay. Able to see my screen?
Yes, sir. So, ladies and gentlemen, this is the details for the doctor. I have also taken a screenshot, Mr. Tam. I will share it in our management committee group, and then we can share it to all our acquaintances. This is really very useful, sir.
Okay.
So again, once again, thank you very much for being part of this this event, and see you in the next event. Thank you. Goodbye. Namaskar.
Thank you.
Thank you, Anuj.
Thank you.
Thank you, Mr. Hari. Thank you, sir, for giving this opportunity. Thank you, Tam.
A lot of opportunities, a lot of programs to run.
Yes, sir. Yeah, it's fun, and yeah, the guidance has always helped. Mr. Hari, was all okay, yeah? Or
It's
there
okay.
any?
I was rushing from the other programs. So I'll just,
Yeah, I know, sir. I know. I know that you were coming from the Toastmasters event, sir.
okay, I think we'll catch up later.
Yes, sir. Thank you, and we will end this particular meeting in few minutes, please. Maybe a minute.
Raj has just joined, is it?
No, he joined earlier, sir.
Okay.
In fact, all of the people who joined, sir, except a few of them, I think they were there from the entire duration. Very, very informative, very innovative.
The time given is very short because he has to rush for the
Yes.
operation. So
Yes. I think, Mr. Hari, I think 1.5 hours would have been the right, for such a informative topic.
we planned 1.5 hours, but I think he was rushing. So
Yes, sir. Yes, sir. And we finished on time, Mr. Hari. Now it's 7:29. We finished on time.
okay, take care.
Thank you, sir. Thank you, sir.
Good night.
Have a good evening. Bye.